Good afternoon, everyone. On behalf of the CPC team and the Medical Education Unit, it is my proud privilege to welcome you all today for the CPC organized by the Department of Nephrology. And to start with, I would request all the dignitaries to kindly grace the dais. Dr. Dhananjai Agarwal, sir, Honorable Vice Chancellor, RUHS, Dr. Deepak Maheshwari, sir, Principal and Controller, SMS Medical College, Jaipur, Dr. Vinay Malhotra, sir, Senior Professor, Department of Nephrology, Dr. Puneet Saxena, sir, Convenor, CPC and Senior Professor, Medicine, and Dr. Monica Jain will join us shortly. Now I would request Convenor CPC, Dr. Puneet Saxena, sir, to please come up and start the proceedings.
Good afternoon, everybody, and I welcome you to the second CPC of this year. And it's very heartening to see the hall getting full. And thanks to our principal sir and our vice chancellor and the Department of Nephrology that they have taken pains to ensure that. And we have been doing these CPCs, and I think this is 13th CPC in the row, and we'll be having almost 27 or 28 CPCs. So after the SOP, we all know that we gather here on the third Thursday, but somehow this is the we change the schedule according to the convenience of the concerned department and the holidays. So first 15 minutes for the presentation, and we all know that the Department of Nephrology has grown by leaps and bounds, and they have a full super specialty block, and they're doing pioneer work in field of transplantation and other things. So we'll know about that, and we have an interesting case following that. So thank you very much, and I hand it over to Shruti. So next CPC, if somebody is here from urology department. Thank you.
Thank you, sir. And I would now request our Honorable Principal, sir, to please come up and address the gathering.
Good afternoon, VC sir, faculty members and students. I think this is really good, really pleasure to see so many doctors in this room. And I think this will continue.
Thank you so much, sir. And now I would request our Honorable Vice Chancellor, sir, Dr. Dhananjai Agarwal, sir, to please come up and address the gathering.
Firstly, respected principal, sir, my younger brother, Dr. Deepak Maheshwari, my few of the seniors which are still here, because most of the seniors, they have been retired, and a few seniors are still there, and my colleagues, my batchmates are still here. And dear students and my additional principals and office bearers, I welcome all of you on the behalf of nephrology department in this CPC. And it is pleasure to see that so much big attendance is there. For that we have collectively done efforts. Residents were regularly informing the all colleagues, and I have informed my colleagues working in the nephrology, this medicine department and other super specialties. Firstly, I want to say for my younger students that I joined this institute in 1978 as an MBBS student, and subsequently as an MD and done DM also, and then became the HOD also. So it may be inspirational for the younger students who are joining the departments or the institute. That this institute is a very big institute, gives lot of to the students, and this have a big name in the throughout the country. All the time when we speaks about the departmental development, ultimately what is the responsibility of the department regarding the institute? All the HODs, they have contributed a lot for the development of the institute. I can enumerate that Dr. K.S. Ratnu was the first head of the department, who was personal physician of the governor at that time. He has started the separate nephrology and other super specialty services. And subsequently, Dr. S.K. Parikh became the HOD next. He has started the super specialty department and DM courses. And I was the first candidate, and Dr. Deepak Maheshwari was also with me as a first candidate in the respective super specialty. Subsequently, now a lot of super specialty has developed subsequently. Then the Dr. L.C. Sharma, he took over as a superintendent of SMS hospital, and he has also contributed at that time in the development of this SMS hospital. Then my colleague Dr. Vinay Malhotra, with whom I am working from last 35 years in that same department, and he became the superintendent, additional principal, and now ultimately is working for the development of the super specialty block. And because with him, we have developed the super specialty in a separate building. and only usually department related to transplantation is there in the super specialty block, and we are working together for the development of the transplantation, which may be kidney transplantation, heart transplantation, and the liver transplantation. So working together is ultimate responsibility of the individual, how we work for this our institute. Particularly, I work from other side of this administration. I worked from the student union, then JARD also, Pathology Association, and subsequently in RMCT also. And I have contributed with other colleagues, with Dr. Rakesh Jain in JMA activity also. So we have taken a lot of things for the institute also, for the fraternity also. And presently, when I am working as a VC also, I have taken a lot of decision in favor of the students, faculty also. Recently, I have eliminated the marking system of the MD, MS, and DA mark sheets. Otherwise, government was thinking to include the marking system for the recruitment. Secondly, we are regularizing the gold medal system because individual departments should have the transparent system of distributing the gold medal. Thirdly, as of the recently has a problem has arisen regarding provisional mark sheets. So for the UG students who is passing the MBBS courses, we are providing the mark sheets, provisional mark sheets just after the MBBS examination. Usually, previously they have to apply for the provisional mark sheet that was coming after 5, 6 months. And with my colleague Dr. Vinod Joshi ji, who is the principal there, we have given the idea of separate institute where our colleagues can go there and as a RIMS also. So that is coming with the in continuation of the aims also, and we'll have around 1500 bed strength also, and all this super specialty will come there. And recently, I have taken the view that what is the use of RUHS inspection, because NM, a lot of time the inspection comes even after NMC inspection. So, is there any utility of the RUHS inspection after the NMC inspection? Even the department gets developed, but after the development of the department, RUHS is going there, and it causes a lot of trouble to our colleagues also. So we are taking historical decisions with my team there in RUHS, and just for the keeping in the mind our institute. So we should have our own responsibility in terms of our responsibility to the department and institute, because whenever we say for the development of the department, at least we should think of the institute also, because the institute gives a name for the development of the department and the individual also. Now for the recent today's case, now I invite Dr. Vinay Malhotra. He will brief about the cases. Thank you.
Thank you, Honorable VC Sir, respected Principal Sir, senior colleagues, my dear friends and residents. Continuing the series of CPC, first of all, I must congratulate Dr. Puneet. We are missing Dr. Monica, Dr. Shruti, and their team for all their hard work and continuing this series of CPC. So today, the Department of Nephrology is going to present one interesting case of multi-system disorder. For the learning of the residents and the students, in nephrology, generally we get three broad categories of cases. One is AKI. Previously, we used to say ARF or acute renal failure. Nowadays, we say acute kidney injury. Then we have CKD or chronic kidney disease, depending on the time duration. If the duration of illness is more than 3 months, we label it as chronic kidney disease. And in between AKI and CKD, we have AKD now, acute kidney disease, or RPRF. Sometimes we get the terminology RPRF, which is the rapidly progressive renal failure. The important point about RPRF is that if left untreated, RPRF will go into chronicity. And problem with chronic kidney disease is that the disease becomes irreversible. Many a times we get the patients, their family, they always say that we are following all your instructions, your medicines, but still the disease is progressing. Last time the creatinine was 2, this time it is 2.2. So the chronic kidney disease becomes irreversible. So checking the progression of disease, making a diagnosis early is very important, because chronic kidney disease will ultimately go into end-stage renal disease, and end-stage renal disease means that the survival of patient is not possible without renal replacement therapy, and renal replacement therapy is either dialysis or transplantation. So in the field of RRT also, with the blessings and help of principal sir, we are doing good work. So today we are going to present one interesting case. Remember, many a times you get the cases of normal size kidney, unexplained renal failure, active urinary sediment, multi-system involvement. My neurology colleagues are sitting also here, some neurological abnormalities. Dr. Deepak Mathur is there, skin involvement, skin rash. Then our pathology colleagues are there. On biopsy, we get this sometimes clue that it should be some multi-system disorder. We get connective tissue disorder sometimes. Then our radiology colleagues are there. So we need the help of so many specialties to make the diagnosis. And it is for the learning of the residents that whenever there is multi-system disorder, we need a team approach to diagnose the case and to treat the case. So to present this interesting case, now I invite Dr. Mahendra to present the case. Thank you.
Good afternoon, respected faculties, dear colleagues, and my dear juniors. Today, our Department of Nephrology will be presenting the clinical pathological case conference. So first, I'll give introduction about our department or the history of our department. So Department of Nephrology, earlier a part of Department of Medicine, was separated in 1990 and established as an independent department under the able mentorship of Dr. K.S. Ratnu sir. Independent Institute of Renal Sciences was inaugurated by the then Honorable Health Minister on 16th of March 1997. This picture depicts our old nephrology department. Then Department of Nephrology was later shifted to the new super specialty hospital in April 2022. 2 floors are now allotted to the department, which houses the wards, the ICU, the transplant, the dialysis, and the lab. The OPD and emergency services are located at ground floor of the building, and the renal transplant OT is at the 7th floor. About academics, DM course was started in 1991. Initially, it was only 1 seat, which has increased to 5 seats per year in 2016, and at present, we are having 7 DM residents per year. Till now, we have 59 alumni serving all parts of the country, with few being abroad. These are our previous heads of department. Currently, our department is divided into 2 units. Unit 1 is headed by William Atherson. He is also medical superintendent of the super specialty hospital. Unit 2 is headed by the Dhananjai Agarwal sir, and we have 2 teaching and non-teaching extra faculties. Regarding publications, we have more than 500 publications in international and national journals, and multiple study projects and ICMR funded studies have been conducted by the department. Throughout the years, we have organized various conferences, including first Indian Society of Nephrology Conference in 1991 and later in 1996, Indian Society of Organ Transplant Conference in 2007 and 2011, various regional conferences such as North Zone Indian Society of Nephrology Conference in 2018, the third vascular and endovascular intervention in nephrology, multiple nephrology workshops, multiple CMEs, and AKI update in 2023. Regarding paraclinical teaching, our department has also started conducting diploma in dialysis technician course since 2018 with a strength of 10 students initially, which has increased to 25 students per year. Till now, total of 110 dialysis technicians have been trained by the department. So I'll be briefing about our department facilities. This is our Radharani ward, which was inaugurated recently. So coming to OPD and emergencies, OPD and emergency both are located in ground floor of the super specialty building. Our department serves as the state's leading outpatient hub, delivering care to the highest number of patients. Specialty clinics, including transplant clinic, glomerular disease clinic, vascular access clinic, and CAPD clinic, are also being run as per the LMC guidelines. This is our ward, which is located on the 5th floor. We have a 60-bedded male ward and 40-bedded female ward with central oxygen supply and monitoring available for optimal patient care on every bed. We have an 8-bedded nephrology ICU on 5th floor with central monitoring system. We have 2 cubicles in the ICU for isolation and infection prevention for at-risk patients. Bedside dialysis and CRRT facilities available 24/7 in nephrology ICU for optimal patient care. We also regularly do acute PD when it is needed. This is our biopsy/procedure room. We are doing over 600 ultrasound-guided biopsies per year, including allograft renal biopsies, and a regular permanent tunnel catheter insertion is also being done for long-term vascular access for hemodialysis. And we are also doing CAPD catheter insertion for long-term peritoneal dialysis. Hemodialysis was first started in the SMS hospital in 1974. Then the department was part of the medicine department. Right now, we are doing around 1800 to 2000 dialysis per month, which are done free of cost. Temporary HD catheter insertion is done regularly, around 300 per month. And we are also doing regular plasmapheresis in the department. So I'll be showing a small video which to depict the hemodialysis procedure. So this is the hemodialysis procedure. So the procedure starts with the hemodialysis machine, which have a dialyzer and their various circuits, including the blood and the dialyzer circuit.
Which is a machine present outside the body, which removes the toxic substances from the blood. A vascular
So for dialysis, we require a vascular access. The access could be a central venous catheter, a AV graft, or AV fistula.
access site is created. At first, numbing the area with local anesthesia and creating an arteriovenous graft. By connecting one of the arteries with the vein with the help of a plastic tube, or an arteriovenous fistula by directly connecting one of the arteries with the vein. Once the graft or fistula has healed, hemodialysis could be performed for the patient. At the start of the process, 2 needles are inserted into the fistula or graft, allowing a circuit to be set up with the dialyzer. Blood flows out of the body into the dialyzer, which consists of filtering fibers that remove waste products.
So these dialyzers are composed of hollow fiber membranes. These are semi-permeable membranes through which toxins are removed, which exit through the dialyzer circuit.
And the dialysate, which acts as an absorbent solution for undesirable substances in the blood. Blood purified in this manner is returned to the body through the tubing into the second needle at the access site. When the hemodialysis
So this is our hemodialysis ward. We have 30 hemodialysis machines and 2 CRRT machines. We have separate machines available for hepatitis B, hepatitis C, and HIV positive patients. And bedside hemodialysis facility is available in nephrology and specialty medical ICU. We also have daycare where it is located at the gate number 3 of SMS, where we are having 2 hemodialysis filtration machines and 6 hemodialysis machines. This is a specialty medical ICU. It is a separate facility for hemodialysis of patients admitted to SMS hospital. Monthly, we are doing around 100 dialysis per month. This is our renal lab, which is dedicated for patients admitted in the nephrology department. We are also collaborating with the Department of Pathology for HLA and CDC crossmatch and Department of Transfusion Medicine for anti-A and anti-B titers for ABO incompatible transplants. So a brief about renal transplantation. First, we will discuss the live renal transplant. Transplant offers patient of ESRD a method to improve quality of life, increase life expectancy, and freedom from dialysis. First live renal transplant was done in the SMS hospital in 1996 by our department. Per year, we are doing around 70 to 80 live transplants. Till now, we have done 689 live renal transplants. And transplantation is being done free of cost under the government scheme to all patients. Outcomes are comparable to rest of the centers with greater than 95% 1-year graft survival and greater than 85% 5-year graft survival. Our department was the one who started disease donor program in the state of Rajasthan. Till now, we have done 88 cadaveric renal transplants and we have retrieved kidneys from various parts of Rajasthan, including AIIMS Jodhpur, Udaipur, and Jhalawad. Cadaveric transplants are increasing every year, and last year, highest number of cadaveric transplants were done till now, with most of the recipients being female. We have also guided other centers in Rajasthan, including SNMC Jodhpur, in starting their transplant programs, and our team has done till now 5 live renal transplants in SMC Jodhpur. So a bit about different modalities of transplant. First is kidney pair donation. Kidney pair donation program or swab transplant offers patient with blood group incompatible donors and cross-match positive pairs to find a suitable organ. Kidney pair donor program was started in the year 2022 and last transplant, just swab transplant was done recently in January 2025. About ABO incompatible transplant. Now blood group incompatibility between donor and recipient has traditionally been a barrier to transplantation. Availability of ABO incompatible transplant has put our institute at par with the leading centers of the world. First ABI transplant in India in our center was done in 2023, and we have developed our own institute's desensitization protocol for ABI renal transplant. This is our pre-transplant ward. We have 7-bedded pre-transplant ward with 4 cubicles for infection prevention isolation. Here, patients are admitted prior to transplant for immunosuppression and preparation for the surgery. Post-renal transplant, patients are received in renal transplant ICU. We have total 8 beds with central monitoring system in every bed and 6 cubicles for patient isolation reduced cost infection. And bedside dialysis and CRT facility is available in transplant ICU 24/7. After transplant ICU, patients are shifted to post-transplant ward, where we have 3 separate rooms for managing renal transplant patients once they are shifted out from the ICU. So now I'll be presenting the case proper. So our case is an 8-year mystery, unraveling the case of edema, epistaxis, joint pain, and renal failure. So we'll start with the patient. So patient is Mrs. X, 42-year-old female, who presented to us with a history of lower limb swelling for past 8 years, recurrent epistaxis for 2 years, joint pain for 1.5 months, and nausea for 15 days. So we'll go back to 8 years back. So when she had her first presentation in around 2010 and 2011, she started having insidious onset, intermittent, lower limb swelling associated with facial puffiness. She was also having facial deviation to the right side with inability to close the left eye. And on evaluation by the local physician, she was told to have nerve involvement on the left side and protein loss in the kidney. She was also told to have high BP and raised creatinine. For these problems, she was started on oral medication, which she took for 6 months, after which her facial deviation gradually improved. And since the deviation was improved, she did not follow up with the physician after 6 years. So from 2010-11 to 2022, she remained relatively asymptomatic. In 2022, she had a second presentation with a different physician when she started having watery discharge from the left eye. On evaluation, she was found to have left eye chronic dacrocystitis. A left dacrocystorhinostomy was done and a lacrimal gland biopsy was taken. The biopsy was evaluated and it was reported initially as having tuberculosis with granulomatous inflammation. But since the patient's findings were not consistent with tuberculosis, the biopsy slide was re-evaluated at a different center, and this time it was reported with suspicion of sarcoid-like granulomas. So at the time, the clinician had a lacrimal gland biopsy report showing granulomatous inflammation with 2 DDs, a sarcoidosis or tuberculosis. A serum ACE level was done, which was 34. Serum calcium was 10.3. A quantiferon TB gold plus was done, which was negative. She was advised ATT on clinical basis, which she did not take. At this presentation, she also had renal dysfunction. So a nephrology review was taken from a separate physician, where she was found to be hypertensive with a BP of 150 by 104. USG report showed normal sized kidneys. A biopsy was not done. And on evaluation, at the time, report showed anemia with raised creatinine at 1.63 and urine routine analysis showing 3+ proteinuria. She was managed with a provisional diagnosis of CKD at the time. So in December 2022-23, post DCR, her watery discharge stopped from the left eye, but now she started having epistaxis from the left nostril. And for the evaluation of epistaxis, an NCT PNS was done, which showed nasal septum deviated towards right side, hypertrophy of the left inferior nasal terminate, and mucosal thickening of the sphenoid sinus. No conclusive report was available. So she was managed conservatively, and for next 2 years, she continued to have intermittent epistaxis with irregular ENT follow-up and managed conservatively. So this cycle continued for next 2 years. Then in February 2024, she started developing new symptoms. These were joint pain, which was insidious onset, intermittent, migratory type, small plus large joint pain, associated with joint swelling and early morning stiffness, lasting for nearly 30 to 45 minutes. There is no deformity in any joint. She continued to have epistaxis, which was painless and intermittent from the left nostril. This time, she was evaluated by a different physician and found to have rheumatoid factor positive, the titer of 101.2. Anti-CC was negative. Here, the creatinine was 2.3. It is worsened further. She was managed at a different hospital in line of rheumatoid arthritis and started on hydroxychloroquine 200 mg BD and triamcinolone injection 40 mg once a week. NCT-PNS was again repeated, and which again showed similar findings without any definitive cause for epistaxis. So over next 3 weeks, she had worsening of symptoms despite SCQ and triamcinolone, and finally she was admitted at a private center in March 2024 from 26/3 to 33. So reports we have available of that hospital. So the report showed anemia and worsening renal function. The creatinine has risen to 6.6. There was hypoalbuminemia with a raised ESR. A urine analysis was also done, which showed albuminuria, suggestive of glomerular injury, and active sediment, again suggestive of glomerular injury. Atomain workup was signed at the center. ANA was negative, NTDS DNA was negative, and finally, patient was referred to us for further evaluation as the cause was not identified and the kidneys were worsening. So she presented to us in April of 2024 with complaints of decreased appetite, nausea, generalized weakness, right forearm ulcer, lower limb swelling, and decreased urine output. On examination, she was a bit hypertensive with a BP of 144/88, pulse rate of 102, respiratory of 22, and SpO2 of 96% of room air. There was pallor present and bilateral pitting PD was present. This time she also had a right forearm ulceration, and systemic examination did not reveal any extra findings. This was the ulcer present on the forearm. It was 2 x 2 cm ulcer over right forearm flexor aspect with slough and mild tenderness. There was no swelling or discharge. Plastic surgery review was sought, who removed the small necrotic plaque under local anesthetic and advised for dressing and wound care. These were the investigations at the time. She was anemic, which was with microcytosis. A reflex testing revealed a normal B12, a reduced transferrin saturation, and a low normal ferritin. There was neutrophilic leukocytosis present, and there was worsening RFT. ESR was raised at 64. A reflex testing for RFT revealed a low calcium, high phosphorus, with a raised uric acid of 10.2. A PTH was quite high at 637. O2 workup was done. The ANA, NTDS, and RF factor ANCA profile was sent. A USG was done, with right kidney was 92 x 35 mm, and left kidney was 82 x 47 mm. The both kidneys were bright with poor CMD. There was an anechoic cyst of 26 x 18 mm at lower pole of the left kidney. Urine analysis showed albuminuria and active sediments in the form of full field RBCs. In view of neutrophilic leukocytosis, the patient was started with broad spectrum antibiotics and initiated on hemodialysis in view of worsening uremia. Urine output during hospital stay was 300 to 400 ml per minute per day, and a USG guided renal biopsy was done. So let's review this patient now. So this is the timeline of presentation. In 2010, she had edema, facial nerve palsy, hypertension, and renal dysfunction. Then, after a treatment of 6 months, she remained relatively asymptomatic. In 2022, she had necrocystitis, a lacrimal gland biopsy showing granulomatous inflammation with proteinuria and renal dysfunction. During the next 2 years, she had recurrent epistaxis. In 2024, now she had joint pain, worsening renal dysfunction, and forearm skin ulcers. So what could be the differentials? So we now know that it is a multi-system disease. There is renal involvement in the form of proteinuria, active sediments in the urine, deranged RFT with hypertension anemia, suggestive of proliferative glomerulonephritis. There is migratory type of inflammatory joint pain also. We don't know what it was. There was treatment. She was treated for RA. It could be SLE, could be a small vessel vasculitis, could be sarcoidosis as there was granulomatous inflammation present previously, could be reactive arthritis. And lacrimal granulomas were present, which was reported as sarcoidosis or tuberculosis, or we don't know whether it was something else. Recurrent epistaxis cause is still not known, and facial nerve palsy cause is still not known. So I'd like to invite Dr. Pragya ma'am from ENT for her review on epistaxis. Sir, working clinical diagnosis till now was a proliferative glomerulonephritis in view of renal involvement with multi-system involvement. So proliferative GN with active sediments, the so long course could be either there was definite granulomas present, so differentials could be a small vessel vasculitis or granulomatous inflammation. Then sarcoidosis does not cause that kind of renal involvement normally. Lupus does not cause granulomas. So it was difficult to fit these pictures. Then there was tuberculosis, which can have very multiple kind of presentations. And she was advised CTD at the time, but it was not taken. So we are still not sure till now in the review what was the cause. We know the renal involvement was because of GN. Yes, sir. Ulcers cannot be there. Yes, sir.
GP, looking at the nasal involvement, I think diagnosis should be first, or microgram is second.
Good afternoon, everyone. So the patient presented to us with epistaxis intermittent from left nostril. Now, there was irregular follow-up, so we don't have the facts about the patient, so we will be talking retrospectively about the case. What could be the causes of the epistaxis in such a case? The first differential can be a deviated nasal septum. Now, as we have seen the CT scan as shown by Dr. Mahinder, the deviation was not that severe, which would have caused an epistaxis. And overall, the epistaxis came from the left nostril. The second differential can be a blood coagulopathy, but the coagulation profile came out to be normal. The third is hypertension. Now, the epistaxis was seen in the period of 2022 to 2024, and this time the patient was under treatment, so the blood pressure was overall controlled. Now we are left with the granulomatous diseases. Among these, the tuberculosis was again ruled out as quantiferon came out to be negative. So we are left with two diseases, the granulomatosis with polyangiitis and sarcoidosis. Both these diseases have a similar symptom, which the patient presents with nasal stuffiness. There can be nasal obstruction. There can be a blood-stained or purulent nasal discharge. There can be crusting. There can be a facial pain along with anosmia and mucoid discharge. With such neck-to-neck similarity in the symptoms, we then further go for a diagnostic nasal endoscopy examination and with or without biopsy. In sarcoidosis, we are able to appreciate fragile mucosa, friable pale granulomas, and appearance of granular mucosa shows us like strawberry fruit. There is involvement of the nasal vestibular skin leading to lupus pernio. Whereas in granulomatosis with polyangiitis, we see irregular mucosal thickening, crusting, adhesions, and fragile mucosa. Although the definitive diagnosis can only be made after sending the biopsy and further histopathological examination. Now, there are some characteristic radiological findings in both the diseases. Coming to sarcoidosis, in CT-PNS, we able to appreciate the punctate osteolysis, bilateral lacrimal gland inflammation, and sinus involvement. There can be a septal perforation seen, as was seen in this case. Again, in granulomatosis with polyangiitis, the CT-PNS will show sinus involvement with evidence of both bone destruction and formation. As we can see here, there is bone formation along with the osteolysis and septal perforation. In MRI, we are able to find fat signal from sclerotic sinus wall leading to the appearance of tram lining. So at the end, I would like to say that the ENT nasal symptoms are the earliest one in the patient with granulomatous diseases, which are often overlooked by the patient and by the doctor. So if we have a brief ENT knowledge about the diseases, we can make an early diagnosis. Thank you.
So at this time, we had CT scans recently done in February of 2024. So we had NCT PNS available. So we got it reviewed by our radiology department for re-reporting. I'd like to invite Dr. Ram for the radiology images. So it was obviously normal. CT was done.
Good afternoon, respected faculty, colleagues, and juniors. So, we got a CT film to review with history of a 42-year-old female with proteinuria and renal dysfunction, cranial palsy, lacrimal gland granulomatosis inflammation, and a NCCT PNS report with following findings. Nasal septum deviated, mural mucosal thickening, and and bilateral lamina papyraceae were normal in previous CT-PNS report. Bilateral optic nerves were, sir, please. Sir, these were previous report. I was talking about this, sir. Previous report, sir. Yes, sir. I am coming to the point. So, apart from the previous CTPNS report, we clearly found a septal perforation that was not mentioned in previous report, and the septal perforation and deviated nasal septum. But there are multiple causes of septal perforation. These are maybe some trauma, surgical, and repeated cautery, digital trauma, nose picking. Some malignant cases, chronic inflammatory conditions like granulomatosis with cholangitis, syphilis, and tuberculosis, sarcoidosis, and some poisons are maybe the cause. Some industrial, cocaine, chronic use, and topical corticosteroids, decongestant, and cause may be idiopathic. Sir, septal perforation. Yes, sir. Nothing, sir.
Would your diagnosis include leprosy?
No, sir.
Differential diagnosis.
Sir, leprosy, we didn't write here, but we included it in differential.
Sir, leprosy does cause septal perforation, but considering other involvements, it was not consistent with the whole of the picture. It was kept as a differential, but later ruled out.
You have included 20 different cases. Leprosy should also have been there. It is a disease now endemic only in India.
Yes, sir. Sorry. So, till now, we had one additional finding, which was septal perforation. So, we had asked the patient to bring the block of the lacrimal gland biopsy. Along with that biopsy block, we had taken a renal biopsy and then got it reviewed by the pathology department. So, I would like to invite ma'am from pathology for review.
Good afternoon, everyone. In our department, we received one single slide of lacrimal gland, and it showed several bits of biopsy tissue comprised of fibrocollagenous tissue lined by stratified squamous epithelium. The epithelium was ulcerated with intraepithelial abscess. There was dense mixed inflammatory infiltrate and numerous granulomas comprised of lymphocytes, plasma cells, neutrophils, Langerhans, and foreign body type of giant cells. In one of the fragment, leukocytoclastic vasculitis was also noted, and there was extravasated RBCs in entire biopsy. So, in the scanner view also, you can see there is dense inflammatory infiltrate, and we can see these multinucleated giant cells also. In this view, in this section, we can see the lining stratified squamous epithelium. It is ulcerated at places, and we can see numerous multinucleated giant cells here. This is the next section. It is showing ulcerated epithelium, and there is intraepithelial abscesses here, and the dense subepithelial mixed inflammatory infiltrate can also be seen. So this is again a high power view showing multinucleated giant cell. Two multinucleated giant cells are seen in this. This particular section shows vasculitis. We can see a vessel, and a lot of neutrophils are present within the wall, causing destruction, and there is also karyorectic debris at places, showing leukocytoclastic type of vasculitis. So coming over to the renal biopsy, we received two slides in our department, one H&E and one PASS. and they had 2 cores of renal biopsy with 10 glomeruli. Active crescents were seen in 6 glomeruli, 3 were cellular and 3 were fibrocellular, and the tuft necrosis was noted in 2 of these. 2 glomeruli were sclerosed and 1 glomeruli had segmental sclerosis. In the tubules and interstitium, moderate IFTA was seen, interstitial fibrosis and tubular atrophy, that was 25 to 30%. There were hyaline granular and RBC cast in the lumen, and the interstitium showed edema and focal dense chronic inflammation. The blood vessels revealed moderate fibrointimal hyperplasia, arteriolar hyalinosis, and fibrinoid necrosis. So we can see active crescent in this. There is a circumferential fibrocellular crescent here. The tuft is compressed, and we can see a active circumferential fibrocellular crescent. Here we can see hyaline cast, then granular cast is also visible here. And this particular EFTA patch shows irregular thickening and wrinkling of tubules. There is interstitial widening and a pass positive material. It is better visualized on empty stain, but since we had just pass stain and HE, so then this particular section shows fibrinoid tuft necrosis of the in the glomeruli. In the inset, you can see there is a pass positive material within the tuft. In the interstitium, there was a area where there was only medullary portion. There were no glomeruli, only tubules were seen. So it showed medullary capillaritis. This medullary capillaritis was seen. And there was a patch, there was a focus in which there was extravasated RBCs. Vascular changes were seen in the form of fibrointimal hyperplasia. Then hyalinosis, which was seen as this deeply pass positive material within the wall, and fibrinoid necrosis. We can see this fibrinoid necrosis, and you can also see there's some karyorectic debris also within the wall. So the DIF study, which was performed in an outside lab, in this 3 non-sclerosed glomeruli were studied, and it showed only segmental entrapment of C3. Rest of the immunoglobulins were negative. So basically, we had a bland DIF. So this is how a bland DIF looks like. There is minimal or no deposition of immunoglobulins. So what is vasculitis? Vasculitis is defined as inflammation of blood vessels with demonstrable structural injury such as disruption of elastic lamina and or fibrinoid necrosis. In 2012, Chapel Hill consensus divided vasculitis into 3 major categories: large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Large vessel vasculitis was comprised of Takayasu arteritis, giant cell arteritis, or previously known as temporal arteritis. They mainly affected aorta and its major branches. The medium vessel vasculitis consisted of polyarteritis nodosa and Kawasaki disease. In the then the small vessel vasculitis, 2 categories were there. One was the immune complex mediated, and another one was ANCA associated small vessel vasculitis. In immune complex mediated, there was it's not. I think it got cropped, but it's it comprises of SLE, IgA vasculitis, anti-C1q vasculitis, and cryoglobulinemic glomerulonephritis. In the ANCA-associated vasculitis, we have microscopic polyangiitis, granulomatosis with polyangiitis, or previously known as Wegener's, and EGPA or eosinophilic granulomatosis with polyangiitis, or previously known as Churg-Strauss. So in ANCA-associated vasculitis, we have autoantibodies against either MPO or PR3. And MPO basically shows a perinuclear pattern on indirect IF with a patient serum incubated on alcohol-fixed normal neutrophils. These are the neutrophils, and you can see these are the lobes of the neutrophils. And in perinuclear pattern, you have perinuclear fluorescence, and one negative eosinophil can also be seen here. In the cytoplasmic, we have fluorescence in the cytoplasm, whereas the nuclear lobes are negative. So post-immune ANCA vasculitis is basically divided into 3 categories: microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. All three of them present as multisystemic disease, and the kidney is more commonly involved in microscopic polyangiitis and GPA, and it is less involved in the EGPA. Then all three of them present with nephritic syndrome, and RPGN can be seen in them. The main differentiating features here are microscopically are there is no granuloma in MPA, whereas granulomas are seen in GPA and EGPA. But EGPA will have asthma and eosinophilia also. And microscopic polyangiitis will have no asthma, no granulomas, there will be only necrotizing lesions. MPO ANCA is more commonly associated with microscopic polyangiitis, and PR3 ANCA is more commonly associated with granulomatosis with polyangiitis. MPO ANCA is more commonly associated with eosinophilic. EGPA has more commonly MPO ANCA association. So to summarize, there was multisystemic involvement in the patient. On serology, there was C-ANCA positivity. There was systemic vasculitis as evident by lacrimal gland involvement and the skin ulcers. On kidney biopsy, there was crycentric and necrotizing glomerulonephritis with vasculitis. The DIF study was totally bland. So a final diagnosis of ANCA-associated post-immune crycentric glomerulonephritis, possibly granulomatosis with polyangiitis with systemic involvement was given. Thank you. Now I hand over the mic to Dr. Mahendra.
You have given incomplete information to the audience. When the serology was mentioned, you only stated C ANCA and P ANCA was sent.
Yes,
Their
sir.
report was not mentioned.
Sir, report came while the time biopsy was being read. So we had discussed, we had got a call from the pathology, and that time report came.
You got it before presenting here, na?
Yes, sir.
It should have been
Patient came very late to attend. Many times we had a limited investigation, and ultimately when we received the patient, we had a already elevated creatinine. So we have made a time seek for the understanding of the other person. So at least we other can contribute in this.
So,
I would like to mention that this is a type of vasculitis, and that is they're very clear with the biopsy reports. Only thing which audience probably want to know whether we had a skin biopsy or not, because the lesion which is shown on the right forearm, it was looking like a pyoderma gangrenosum, PG. PG has got association with the kidney as well as spleen involvement. There are so many reports, so we probably missed the spleen. But there is a gap between 2012 to 22. The patient was missing. But somebody raised a very good question. We have not thought about leprosy. And for leprosy, because pathologists did the staining, probably they have missed the fight stain because they have to do the fight stain to see the leprosy. But no doubt, by all the evidences, it is very clear. It is a leukocytoclastic vasculitis involving the small vessels with granuloma changes. So the whole disease goes in the favor of vaginal granulomatosis. But we have missed two things which are very important: leprosy as well as pyoderma gangrenosum. Thank you.
Lesion was clear cutting the skin, but the skin biopsy was not done.
Because we have received the patient when the creatinine was markedly elevated, and in kidney biopsy it was showing crescentic glomerulonephritis, and our purpose of the RPGN was sorted out. And usually this vasculitis also causes the skin involvement. Regarding the leprosy, usually lepromatous leprosy usually causes membranous involvement. Then other types usually they may cause minor illness. Usually they are not presenting with crescentic glomerulonephritis and renal failure. The renal failure, diagnosing the leprosy usually connect in leprosy syndrome. It is very unlikely, and we were able to diagnose the thing on the basis of kidney biopsy that skin lesion was probably vascular lesion, which because of the renal failure were not healing and converted into the necrotic large lesions.
So by now everyone is clear about the final diagnosis. So our final diagnosis was acute on chronic kidney disease. The etiology was granulomatous granulomatosis with polyangiitis with multi-system involvement, along with hypertension and anemia. So for this treatment, in view of rapid progression, methylprednisolone pulse was given, followed by maintenance immunosuppression on oral prednisolone, and cyclophosphamide first dose was given. She was started on quatrimoxazole prophylaxis also. Patient improved clinically and was discharged on maintenance immunosuppression, but due to chronicity, she remained dialysis dependent. It related follow-up also. So what are the challenges in management of ANCA vasculitis? ANCA-associated vasculitis patients, they
CPM बस दिया, उसके बाद में पेशेंट को फॉलो किया, उसका ट्रीटमेंट में और प्रोटीन में क्या फर्क पड़ा?
sir,
Regarding that,
yes sir, we followed the patient for 3 months.
Ultimately, she remained on the dialysis dependent. There was no renal recovery. So ultimately, we thought, there was no renal recovery because histological picture on the biopsy was showing a lot of chronicity in spite of the treatment, and ultimately we planned for the maintenance dialysis and transplantation.
Did he collect your questions? Collect your questions and ask them.
नहीं satisfied.
Follow up भी आएंगे question. Follow question.
Sir, we got a NCS done of all 4 limbs, which is normal. We did not get MRI brain done. Yes, sir. So, yes, sir?
Pulmonary involvement.
So we got HRCT done also, which did not show any granulomatous inflammation, no GGOs, nothing else was done, no consolidation was done. So, challenges in the management of ANCA vasculitis patients. We have diagnostic challenges since the disease involves many systems at different time in the history. So, the patient presents with a remote history of something else, and acute presentation will not be able to make a diagnosis. And for diagnosis, both serology and biopsy is required. A serology can be positive in many cases without the disease also. So these two treatment, so serology and biopsy can be done at a tertiary care center also only. So diagnostic, these patients remain undiagnosed for quite a bit of time. There are treatment difficulties as the management require induction and maintenance therapy, and the immunosuppression is quite high dose. So they have treatment related side effects. There is also high likelihood of disease relapse even after remission is achieved. And even for transplantation, the disease activity should be absent for at least 6 months before proceeding for renal transplant. So our take-home messages would be, in patients presenting with diverse and non-specific symptoms over time, it is crucial to consider rare or uncommon diagnosis, especially when a unifying diagnosis is elusive. A renal biopsy can be pivotal in diagnosing underlying systemic conditions such as autoimmune disease or vasculitis. Referring to a specialist early in the diagnostic process can prevent delays in diagnosis and treatment. And multidisciplinary management should be strongly encouraged in patients with complex multisystem disease. So now I would like to invite Dr. Arjun Agarwal for discussion on challenges in renal transplantation.
Good afternoon, everyone. So now we will have some small discussion on challenges in renal transplantation. So traditionally, a patient could receive kidney from same blood group or from O blood group, as O being the universal donor blood group. Approximately 20 to 30% of the patients are not able to get kidney from their relatives because of blood group mismatch, or also called as blood group incompatibility. So what are the options? So there are 3 options available for such patients. So first is cadaveric transplantation. Cadaveric transplantation is the only hope for some patients without blood group matched living donors. But what is the issue with cadaveric transplantation? So the wait list is too long. And what are the reasons behind that? What's first is poor awareness in the general public. There is lack of infrastructure at district hospital from brain death declaration, organ storage, and organ transport. Also, there is limited number of brain death declaration. There are also religious factors and myths regarding cadaveric renal transplantation. So what can be the possible solutions to increase the cadaveric transplantation? So first is reimbursement to donors for medical and funeral expenses. And NOTO has recently started giving 11,000 rupees for the donor family for the same. Then public awareness is very important, and also medical awareness in ICUs for brain death declaration. The second modality is kidney paired donation, which is also called as swap transplantation. Now we will be discussing about what is swap transplantation. So first, with an example, there is one pair in which donor is A positive and the patient is B positive. So due to blood group incompatibility, this donor cannot donate kidney to the patient because the patient's blood group is B positive. So now we have one more pair in which the donor blood group is B positive, but this donor can also not give kidney to the patient because the patient's blood group is A positive. So what we can do? So we can do swap transplantation in which donor of the second pair will give kidney to the recipient of the first pair and donor of first pair will be donating kidney to the recipient of second pair. Now there is third option for the same, which is called as ABO incompatible transplantation. So what is ABO incompatible transplant? So another same scenario in which donor blood group is A positive, but recipient's blood group is B positive. So donor cannot give kidney to the recipient. There is no other donor available, and swap transplantation sometimes cannot be done because of no suitable age and GFR matched pair. So what we can do is we can transplant this A positive kidney into the recipient of B positive kidney after doing desensitization. So this is the desensitization protocol. Our center has developed our own protocol in which we use rituximab to stop formation of antibodies, and we do plasmapheresis to remove the existing antibodies. And in our country, there are only 5 to 6 government colleges which are using all 3 types of modalities, and it is a proud moment for us as SMS is using all 3 types of modalities for transplantation. The gravity of ABO incompatible transplantation can be understood by one example, as we can still not transfuse incompatible blood to the patients, but we can do transplantation of incompatible blood group kidney transplantation. Then there is one more topic which we should focus on, which is gender disparity in renal transplantation. So women are often underrepresented as transplant recipients while being overrepresented as living donors. If we look at 100 transplants in our institute, 80% of the recipients will be male and 80% of the donors will be female. This disparity is very obvious in all the other institutes as well. And females have additional risk factor in the form of pregnancy-related AKI, which is also called as PRAKI, which may lead to CKD and warrant renal transplant. We get around 20 to 30 patients with PRAKI who lead into CKD and need renal transplant. Families tend to prioritize female CKD patients. Recently, we have seen that families are willing to register female patients for cadaveric transplantation, but still the awareness is not that great as they are not giving female patients living kidney transplantation. Despite that, many female CKD patients remain on maintenance hemodialysis and they face higher morbidity and mortality due to delayed interventions. So there is an urgent need for policy reforms to prioritize female CKD patients for both live and cadaveric transplantation. Thank you.
Thank you very much for a brain teaser, and we had a very nice multi-system case which should be there ideally. And I just have 2 humble requests to make. One is to principal sir, that since the nephrology department, I think, is the department which sees most of the references, because every department has something, some or the other patient, probably every 3rd or 4th patient suffering from kidney disease. So if we can develop a small dedicated facility of dialysis in SMS building also, because there are only 3 machines and it is very difficult to shift the patients to the super specialty block. So Superintendent sir is also nodding his head, and I think he agrees to it. So if we can develop that, that is a request. And second request is to the concerned departments who are presenting. So please do a rehearsal for a Hazel-Fro presentation over here, how best you can use the audiovisual services, and get in touch with the CPC team with your case before, and that would be preferred as we have done in the previous CPCs. It was a very good case, and I remember that in 2016, Dr. Aradhana Singh presented Wagner's granulomatous as the first CPC in the old auditorium. We had medicine CPC, I think she must be remembering. So we had the same case again here. So thank you very much. And I will request Principal Sir, he was very occupied that time, and we want him to address the gathering. Thank you.
I think it is a very well presented CPC, both in terms of number of attendees and the interactions. Dr. PD, Dr. Prachish, and I think उत्साह इसी तरह बना रहना चाहिए, and this CPC should go long way. And as far as Department of Nephrology is concerned, I want to say a few things. First, when we were in undergrades or postgrad, the main approach was palliative. Now it is more curative. So they are doing very good work in curative nephrology. That number of transplants are very high, and in the last year they have done maximum number of cadaveric transplants. So I think we should congratulate both nephrology and urology departments for this achievement. I think they have done 19 in 6 months, in last 6 months, which is, I think, really remarkable. And the other thing is, I think they are running 3 facilities for dialysis. They have less number of consultants. I think 4 of them are only there. And if they can run another facility in the SMS premises, I think we are ready and forthcoming. But they have to decide whether they can run a third facility or fourth facility in the SMS. I think Dr. Dhananjai will do it. So Bhatti, go ahead and put some hemodialytic.
Already planned. I have requested you for the 6 more hemodialysis machines, and there is a separate wing for this dialysis. Opposite just a new 2D ICU. There are the 7 bags that is dedicated for the dialysis.
I think
we are planning to have one fixed RO machine there and one movable RO machine, so that we can do dialysis and at various places.
I think that will be great. If the hospital administration and the Department of Nephrology both are ready, then definitely the references to nephrologists are maximum number, and shifting patients from the main building to SSB is sometimes cumbersome. So I think this is a very welcome step, and I thank you both, Dr. Bhatti and Dr. Dhananjay, and the principal office will do everything to purchase the new machines in the shortest span of time. Thank you.
What is the request है कि medicine में nephrology में reference से आरक्षण इसलिए इस building में भी जो है ना पूरी सी व्यवस्था ढंग की है.
Regarding Dr. PD, another thing that we have a regular references. Daily we are getting 30 to 40 references. And our resident, whenever they see the references, one day the Dr. Manish has commented that your references is just like a seal. So they are taking the photograph of the reference notes, and subsequently they are presenting to us next day whatever they have written, and then we evaluate the references, and again we are giving the regular guidance and follow up also for the references. We take a respect to us also that referring the patient to us, and regularly we are following all the references. Not only whatever the residents are writing, and they are learning from them also how they manage their things and how they can coordinate with each other. And regarding the dialysis, we are doing the regular dialysis at RUHS also, in SMS also, wherever the facilities are, our residents are regularly going there, and they can do the dialysis at all places. Thank you.
Anesthesiologists also work for optimization, blended and cadaveric transplant, renal transplant also.
So a big round of applause for anesthesia department also. You're doing a tremendously good job. और वो कहते हैं ना कि पर्दे के पीछे रह जाते हैं, हमारा जिक्र भी नहीं होता, तो आपका जिक्र बिल्कुल लाउडेड है. एक राउंड ऑफ अप्लॉज फिर से एनेस्थीसिया डिपार्टमेंट के लिए, विदाउट विच many of the department will remain incomplete. Pathology also, yes.
Sir, you have pointed out that cadaveric transplant is a CPC. Cadaveric transplant is the way ahead to reduce the waiting list of CRF patients. I want to make a comment here that only the Department of Neurosurgery is providing you with deceased donor transplant. There are many patients in various other departments who become brain dead, and no other department works for optimization, neither contacts us nor the anesthesia department to have those patients as cadaveric donors. So, on your behalf, I would like to request all those departments who have these patients who can be used as deceased donors to please make a contribution to this program, so that you know that Rajasthan is the number 5 state in the country in cadaveric transplants. So I think if all other departments contribute to this, then we can make a difference in the waiting list of the CRF patients and even liver failure patients and those patients who require heart transplant. Our college is equipped to do all these transplants. Thank you.
So प्लीज लाइट्स ऑन कर दो, इतनी अच्छी सीपीसी हुई है, इल्यूमिनेटेड लाइट तो बनती है अब. So please on the lights, and thank you all and each one who is present here. I must congratulate Dr. Dhananjai sir effort. It is inspirational for all other departments. Urology, now you have a challenge कि audience इतनी ही होनी चाहिए. Then only we are able to achieve the brainstorming. पूरे कॉलेज में सर, लेकिन इन्होंने इंटीग्रेट किया सबको कलेक्टिव एफर्ट है, no doubt about it. See, I may forget the name of some persons, but everybody, that was a great